There we go. Now I'm recording. Any questions that I can answer, clarify, explain, etc.? Nope, that is for maternity. Like Pitocin and stuff. But body surface area, remember what we did a long time ago on your dosage calc? Y'all might want to revisit that because remember that's a PEDS calculation.
I have a question about the treatment of juvenile idiopathic arthritis. So you said, I know one of them was promote mobility and preserve joint function, and then another one was bed rest. So are you just talking about range of motion in the bed, not actually like up and walking, right?
Right, and what I mean by bed rest, they're not on bed rest all the time. They're on bed rest at that initial onset. And really the biggest reason they put them on bed rest at the initial onset is not so much for the joints, but to decrease any risk of getting rheumatoid or rheumatic heart disease. So it's not, they're always on bed rest, it's just in that initial onset. And then, but yes, they can still do range of motion in the bed.
Got it.
Good question. Yep. And actually, once they get past that initial onset, as they're more in that maintenance stage, they will encourage ambulation walking using those joints to prevent them from getting stiff and having increased pain because of that. It's a great question. Let's see. I'll give it a couple minutes, see if anybody else is coming.
And one more thing, I was looking in the book for the which one was it? The botulism. The difference between infant symptoms and general signs. Do we need to know both of those?
Just overall symptoms. They start to have, the weakness, paralysis that progresses into muscular or respiratory failure. Kind of the overall basic. Yes, that's a great question. So Jennifer asked if myelomeningocele and spina bifida is the same thing. Myelomeningocele is a type of spina bifida cystica. So when we're looking at spina bifida cystica, this is where they have the pouch on the outside of the body that houses whatever is not enclosed in the spinal column. Meningocele is where it's only the CSF and the meninges. So the spinal cord is still located in the spinal column. It's just where the pouching out is of the meninges and the CSF. Myelomeningocele is where the spinal cord is also coming out in that pouch. So it's a little bit more severe because there's more stuff that's been moved where it doesn't belong, if that makes sense. So yes, they're the same. Myelomeningocele is one of the types. I understand. Yeah. Oh, sorry. Yes, so it is the same nursing interventions as far as like your post-op, your pre-op, you're still going to put them in prone positioning. You're still going to watch out for risk of infection. Typically, myelomeningocele, because the spinal cord is displaced, has more significant long-term complications like immobility and things like that, but your care is going to be the same. We're still going to focus on care based on the severity of their symptoms and providing them as much functioning and things like that we can. So it's really technical differences, anatomical differences, I guess. Let's see. promise I don't have corona. I don't know why I'm coughing all of a sudden. Or I don't think I have it. Let me rephrase. You know, you never know. Watch me say that and I wake up with like Temple 104 tomorrow. Yeah, I'll cough with allergies too. Yeah. Mine have actually been not as bad this year, and I think it's because I've been inside so much, although you would think that would stem it too, just from the air being held up. So rheumatic fever, when we say a patient has rheumatic fever, this is where they have symptoms of strep complications. So rheumatic fever, rheumatoid arthritis is one of the things that fall under the umbrella of rheumatic fever, I guess is the best way to put it. When you get rheumatic fever, it causes those post-rheumatoid complications like rheumatoid arthritis, cardiac disease, kidney failure, things like that. So think of JRA or JIA as falling under that umbrella of rheumatic fever. You'll get rheumatic fever first, then you'll get those post complications. Or they start while they have the rheumatic fever and continue. Let's see, we got 16. Alterations, so it means physical growth, not just skeletal, but just physical growth in general. So fine and gross motor would fall under that. Absolutely. It could be because we have covered hip dysplasia before when we did newborns. So don't forget about hip dysplasia. Anybody got tips of how they're doing vaccines? I've given a couple tips in that Nursing Care of Children comprehensive ATI book that's under intro. It has the Dr. Hip acronym, and Registered Nurse RN uses the same acronym, but if y'all have something else you use, good, I'm glad. Some people like that YouTube video, some people find it more confusing, so it's really just whatever you find. But if anybody else found something else that they found helpful. I love Registered Nurse RN. I'll be honest, I like her accent. I could listen to her talk all day. But, I mean, she's really good, too. Don't get me wrong. And I like how she embeds quizzes into her videos, too. Oh, really? I like Registered Nurse. Oh, you mean he hates it because of her accent or just her videos? Yeah. I love listening to her talk.
No, I was gonna say we used to watch it in clinicals for med-surg, and Jeremy used to make me turn it off because of the accent. He couldn't take it.
Oh my goodness, I love her accent. I love to hear her talk. That deep southern drawl. If you haven't tried her, try it because she does. It's not just lecture, but they're kind of short. And she embeds quizzes and stuff into her videos so that you can like watch the video and then take a little quiz on the information that helps reinforce it. And of course, I'm sure everybody knows Kathy Parks because she's a legend.
Miss Martinez, did you ever hear of the nursing.com app? The nursing app. I was going to ask you, is that app helpful?
I've promoted it many times.
Oh, okay, because one of the students told me to get that app, and it has like all the classes. I wanted to see, is it this similar to ATI? Like it's
How do you mean similar? I mean, it's not laid out the same as ATI.
not the exact same thing, but I mean, like, are they interchangeable? Like,
No,
is it good?
they're
No.
interchangeable. They are just a different resource.
Oh, okay.
So as far as the Denver, I would recommend at least reviewing the Denver because it does give you a pictorial view of growth and development. It might help you remember it, but as far as knowing exactly what should a 12-month-old do based on the Denver, you don't have to memorize the Denver, but it is another method to help you remember growth and development milestones with certain ages if you like picture visuals. All right. Let's pull this up and see if y'all know the answers. I figured out how to do and collaborate to go back and forth. See if this app's right for me. All right, is it not? What do y'all see on your screen?
We can see it, Ms. Martinez.
You can. Okay, hold up. What do you see now?
Blank, black screen.
It won't work. I was hoping it would. All right, well, that's all right. I can go back and forth on this. So, let's do the first one. Guilty feelings associated with illness, such as thinking that bad behavior was a cause for their hospitalization, is often seen in which developmental group?
Preschool.
Y'all think preschool? I think you're correct. Preschoolers, remember preschoolers, and you'll see this a little bit in toddlers as well, especially towards the end of toddlerhood, like around 3, where they start having the magical thinking, they start having the animism, they start really using their imagination. That's where part of this comes into. So instead of recognizing that they are sick because of illness, they think they're sick because of something bad they did, like yelling at their mom or whatnot. So especially in preschoolers, you'll see this. What are some things we should include in documentation when a patient is discharged? I know it's going to end up going blank on me. Vital signs, yes. What kind of meds? Like that we gave them or that they went home with? Yes, teaching. That's a huge one. So we need to make sure we're documenting whatever teaching we give to the parents. So we want to, with vital signs, we're also going to document their condition. Are they alert and oriented? What do they look like? Who are they discharged with, and what was their mode of transportation? Patient was discharged via wheelchair with both parents present, placed in personal vehicle, whatever it was. Teaching is a big one, though. We want to make sure we're documenting what we're teaching those patients or those parents, either way, so that we have that in their chart so we can keep a running thing of that. All right. What are some measures to help a child with adjustment to hospitalization? Yeah, so objects like toys, if they're stuffed kind of toys, you want to make sure that it's theirs. They're not shared. Allowing them to bring familiar objects, letting them touch equipment that's safe to touch, such as a blood pressure cuff, stethoscope, things like that. One thing we can use for all ages, though, is to orient them to the unit, orient them to the procedures, what's going on. Here's where you find the playroom. Here is what time we do meals, and also keeping lenient visiting hours. And this is pre-COVID. Typically, we would have lenient visiting hours, or even lenient who could visit, so that it would promote those interactions and make them feel more at home as best as we could. In this stage of separation anxiety, the child appears more attached to staff than to parents. It's an ego defense mechanism that can cause psychosocial problems in the long term. Which type of separation anxiety did we talk about is a problem?
Is it detachment?
Yeah, very good. So detachment, or you'll also hear it called the denial phase sometimes, either one. The first two that we talked about protest, which is where they're standing there or sitting there crying and screaming and holding onto your leg, throwing a fit. And then they'll have the despair phase. I was trying to think of the other one. The despair phase, where they're kind of like sitting in the corner, pouting, but sad, but these are normal. If they go into that third stage, denial or detachment, where they seem to be more interested in either the staff, their toys, parents come to visit and they just keep playing like whatever, that can indicate this stage, and it can cause permanent psychosocial problems if it continues. Stages that experience separation anxiety, it's all of them. So this starts possibly as young as 4 or 5 months of age. So you're starting with the infant stage, and it goes through all stages. But what changes once you get to adolescence is it is a separation from their peers, not their parents, that causes them separation anxiety. And that's where those lenient visiting hours can come in as well. Not only hours, but lenient visitors, so that their peers and their friends from school can come visit them, and that can help decrease some of that separation anxiety from their peers. All right, the best therapeutic communication method to use when providing education to a child about a procedure, a child or an adult, really. Yep,
Listening.
teaching, honesty, yep. Being or at least being careful what medical terminology we use, absolutely, especially your younger kids. Being careful about what words we use. One thing we can do, though, is first ask them, just like we say assess and lessen distress. The first thing you do before you implement, you need to assess. So assessing what they already know about something, and then based on what they tell you, then gauging your teaching on that. So if they know a little bit, then you don't need to teach them that. You can leave that out and talk about something else. Or you may have to clarify something that they say, this is what I believe, and it's incorrect. You can change that information as well. Yes, like Stacy said, putting it on their developmental level. Ashley said that as well. That is absolutely. We want to make sure it is not above their head. And that's with any patient, even adult patients. If they are not cognitively at the level you're explaining information to them, then it's not going to do them any good. This is a good technique to assess a patient's feelings as well as use distraction in a school-age child. What can we do to assess feelings and distract them?
Play?
Yes, what kind of play?
Therapeutic play?
Specific type. What can we have them do?
Is it distractive play?
Drawing.
Yes, art therapy. So drawing or art therapy we can use to, not only is it a good distraction method, but sometimes, well, adults as well, sometimes people can't put into words how they feel. They feel scared, but they can't describe that they feel scared. So if you have them draw a picture, that can be an excellent communication method. As children get older, like teenagers, even older school-age children, sometimes if they don't want to draw, having them journal is another way. Having them just write everything can help them pinpoint those feelings instead of trying to find specific words to describe it. Yep, so drawing or art therapy. What pain scale are we going to use in a 5-year-old patient? I guess it depends on if you're talking about ATI or non-ATI here, what answer you're going to put.
Numeric scale.
Which
According
one?
to ATI, the numeric.
Yes. So you could say either numeric or FACES scale. So FACES scale, remember, you can continue to use it past then. So it wouldn't be inappropriate to use a FACES scale on a 5-year-old. It's just numeric would be, 5 would be the youngest. So it could be, in this case, based on ATI, either the FACES scale or the numeric scale. Either one would be correct for this age of patient. What would we use in a 1-year-old? Man, I think y'all know that one. That is your FLAC scale. Very good. So your behavioral scale, a 10-year-old, that one's pretty easy. That one is your numeric scale. Once we get to that age, they are considered to be on a relatively adult level as far as determining pain. All right, this coping mechanism occurs when patients revert back to previous behaviors. It's an ego defense mechanism. What's that?
Regression.
You got it, regression. So regression is not abnormal. If patients show behaviors that they that are below their growth and development level, but it's temporary and they didn't have them before, that is normal as long as they go back to their normal behavior within a couple weeks of discharge. Yeah, exactly, Shreen. Bedwetting. That's a great example. What is the best method to associate time with a toddler or preschooler? If you tell them it's noon, they have no idea what that means. They can't read a clock. They don't even understand what time on a clock means. What you think? How do we relate to time with toddlers and preschoolers? Yeah, using periods of the day. So like Jeanette said, lunchtime. That's an excellent one. So instead of saying noon, we use times of the day or daily events. So noon, bedtime. They understand what that means, but they don't understand what 5 minutes means. They don't understand what 12 means. They don't understand those concepts. So relating it to something that happens during the day. This should never be done when administering a bitter medication to a child. What should we never do just because it doesn't taste good?
Put it in food.
Yeah, food, drinks, any kind of volume of liquid. So if we do mix it with some, it should be something very, very small, such as a little bit of jelly or a little bit of ice cream, a little bit of honey if they're over 12 months. to mask the taste, but it shouldn't be in any kind of volume. And it definitely shouldn't be in anything they need for nutritive value, like your milk, your breast milk, things like that, because then they can develop an aversion to it. Oops. Here we go. Good job. I think y'all know that one pretty well. These are priority education points to include when teaching parents about med administration in any group. Yes, storage, great point. We want to make sure they're storing it correctly. If it needs to be refrigerated, it stays refrigerated. Things like that. What about some things that we might do for all patients? Like, for example, making sure they finish the entire dose. Do you know how many people take antibiotics, and I'm included, I can't say nothing, where they have, say, 10 days of amoxicillin, they feel better after 6, and they stop taking it because they feel better. Y'all know this from farm. We never stop taking antibiotics, or we never discontinue a course of medication prematurely just because we feel better, unless we're otherwise instructed to. Making sure that they have an appropriate measuring device, like Kenya said, making sure they actually use a cup or a syringe with measuring marks on it, not just a spoon out of the kitchen. What do you mean, can you make resistant correct?
Sorry, I typed really badly because I was typing quick. I was trying to say, if you don't finish the antibiotics and got, like, God forbid, got another infection, they'll be resistant to the first antibiotic, correct?
That's it. Yep, that's exactly what it is. They can develop resistance, or they can create superbugs. That's how we get antibiotic-resistant bugs. That's how we get superbugs, is when you take antibiotics, of course, they kill off the weakest first. So when you get rid of, let's say, 80%, you've gotten rid of 80% of the bacteria, well, great. The 20% that's left when you stop taking that antibiotic early is the strongest 20%. And if those are left, they're going to create new bacteria that are even stronger, and that's where we get those resistance. So taking the entire course, using a precise measuring device, those are some important things with any age group, including adults. All right, let's see if you can comprehend what developmental group this would be. Encouraging parent presence, which that could be all of them except for adolescent. Telling the child they can yell or cry, using distractions, modeling the behavior. These are all important preparations for, what developmental group? What group would be some things we would use this with?
Toddlers?
Yep, toddlers and preschoolers. So toddlers and preschoolers, we want to tell them, I do all the time, it's okay, you can yell, you can scream, you can cry, just keep that arm still, like if I'm drawing blood or something like that. I oftentimes model when I'm doing, but especially strep, I find myself, I'm not even consciously thinking about it, and say, do this, and then I open my mouth wide, because they're going to mimic my behavior as I'm doing it. So those are all techniques we can use to help increase compliance in that population. Toddlers and a little bit of your younger preschoolers especially. Y'all so smart. This is one of the most common opioids used in pediatrics due to quick onset and short half-life. There's two we talked about. Which one is better for quick onset?
Fentanyl.
Fentanyl, very good. Which one is better for decreased side effects?
Is it morphine?
It is morphine, very good. So the two opioids we use in pediatrics is fentanyl, and fentanyl is good because it is more rapid acting. especially if you have a patient that's in severe pain, and it has a shorter half-life. So if you're having side effects, it's going to clear the body quicker. We like morphine, though, because it has a lesser risk of side effects. All right, the most important in establishing trusting relationships with the adolescent population, I'm pretty sure y'all know this one by now, privacy and confidentiality. Once you get to that adolescent population, they need privacy, confidentiality to maintain that trusting relationship with their caregivers. And really that goes into, that's where they're building into that adulthood. These are common reactions of siblings to children with common illness. That should not say common, that should say chronic. Common reactions of siblings to children with chronic illness. What you think? See, it keeps
regression.
What's that?
Regression.
Not regression. Jealousy, very good. So jealousy and resentment are common reactions to siblings that have a sibling that has a chronic illness. They're focused on the fact that, and it's not because they truly don't want their sibling to be taken care of, but because oftentimes they are left alone or left with babysitters or other family members. They feel like all the attention is being placed on that sick child. Sometimes they have to take on extra roles, especially your older siblings. They may have to basically play mom and dad sometimes. Exactly, the parents are busy with the sibling. So jealousy, resentment are very common reactions to siblings of children with chronic conditions. Right, exactly. It's totally understandable. Jerking muscle movements with stimulation is characteristic of what disorder? What specific type?
Spastic cerebral palsy.
You got it. So spastic cerebral palsy is the type with jerking muscle movements with stimuli. Now, the writhing, jerking movements at rest, you'll see with dyskinetic cerebral palsy. And what med do we use? I know y'all know this one.
Good old baclofen.
Good old baclofen. It's a good drug. All right. What is often the first sign of hearing impairment in an infant? Lack of what?
Startle reflex.
Yes. So if they are lacking the Moro or the startle reflex, that can be a sign they're not hearing those stimuli that are causing them to have that reflex. And an older infant or a toddler, they'll have impaired speech development, and there's lots of ways that can present. It could be stuttering, it could be delayed, like they're not babbling at 6 months, 7 months, 8 months when they first start babbling. It could also be monotone, because if they have hearing impairment, they're not hearing those tonal inflections that they would hear from older people, like your tone as part of your nonverbal communication, then they won't have those. So their voice will sound monotone because they're not hearing those inflections that they would understand as part of conversation. Right, exactly. That's exactly it. Ben Stein. Where'd my cursor go? Ah, there it is. That's exactly it. All right, this assessment finding is considered a neurosurgical emergency because it's a sign of brainstem herniation. What is a sign of brainstem herniation?
Fixed and dilated pupils.
You got it. I think y'all might have listened to me today a little bit, or sometime in the past week. So fixed and dilated, or sometimes you'll hear lay people call this a blown pupil. This is a sign because of the increased intracranial pressure in the head. It's pushing that brainstem out that occipital opening in the back, causing those pupil changes. Very, very bad sign. Vomiting, lethargy, high-pitched cry, bulging fontanel, and fever are all symptoms of what in an infant? I'll tell you one thing. The fever is an indicator how it's different. So with the fever added to it, what do you think it might be a sign of? So the vomiting.
Infection of the VP.
Now that's a good one. That could be VP infection. It is an infection. So really looking here, it was meningitis. So with meningitis, they'll have a lot of those symptoms of increased intracranial pressure, but the fever makes a difference. But Jeanette made an excellent point. These all put together can also be a sign of VP shunt infection. So the other symptoms, the vomiting, lethargy, high-pitched cry, bulging fontanel, they're all signs of increased intracranial pressure. Adding that fever on top of it means there's some kind of infection going on that's causing that increased intracranial pressure. So when we're talking about symptoms in an older child, these are going to be symptoms. Some of these will be the same, like the vomiting and the lethargy, for example. You can have that in older children as well. But symptoms that they can tell you about, like photophobia, phonophobia, headache, nuchal rigidity. Nuchal rigidity is a hallmark sign of meningitis, where they have stiff neck and can't flex their chin down to their chest. So when we have a patient with meningitis, what is our number one priority when they come in? Before we ever treat the patient, what is our number one priority? I keep coming up with white boxes in the chat.
Isolation.
Isolation, very good. What kind? Oh.
Droplet.
Love it. Droplet precautions. So Amy NCLEX loves to ask you about precautions. Looking at recognizing that when you have a patient that comes in with an infectious disease, even potential for an infectious disease, your priority is to protect the public before protecting an individual person. So you need to put them on isolation, specifically droplet when we're talking about meningitis. I keep accidentally, there we go. So droplet precautions. We're also going to put them on seizure precautions. Now, not every patient that has meningitis has seizures, but they have the potential to have seizures. So things like padding the bed rails, making sure the bed is in the lowest position. We have them on fall rest, things like that to watch out for those things. Neurological monitoring. When patients have any kind of neuro complications, whether it be meningitis, head injury, whatever, usually minimum Q2 neuro monitoring. We want to decrease stimulation, just like with our other increased ICP situations. Turn down the lights, eliminate as much extra noise as we can. And we also want to elevate the head of the bed at least 30 degrees so it's not increasing that intracranial pressure. All right. Covering one eye or tilting the head to read may be symptoms of what two vision disorders that we treat them the same way? Yep, strabismus is one of them. What's the other one?
Amblyopia.
You got it, amblyopia. So amblyopia and strabismus, the treatment is what?
Eye patch.
Yep, we're going to patch the good eye so it forces the bad eye to work and hopefully corrects the problem. What are two preventative measures for Reye syndrome? How can we prevent children from getting Reye syndrome? There's one y'all always know, but I want to see if y'all think about the other one too.
Vaccine.
That's the one that people usually forget. Very good. How else can we prevent Reye syndrome? Telling them to avoid what? Yes, no aspirin. So the two ways that we can prevent Reye syndrome is one, avoiding salicylates, which is the drug class for aspirin, and making sure patients are getting vaccinated against these viruses so they're not contracting them and taking the aspirin. Reye syndrome is I've never actually had a patient with Reye syndrome because it's extremely rare nowadays for two reasons. One, our education of the public. teaching them not to take aspirin, and now that we have readily available vaccinations, whether people use them or not. I'm not going there, but you know. All right. 3 components of the GCS, or Glasgow Coma Scale, are what? What are we evaluating when we do a GCS?
Verbal response.
Verbal?
Opening.
What was the other one?
Eye-opening.
Eye-opening. And motor. Can you set very good? Y'all are killing it. Eye-opening, verbal, motor response. Those are the 3 criteria we're assessing to give us a compiled score to give us an idea of where they are. And if we need to do any interventions or what interventions are necessary and how severe their level of consciousness is. This type of generalized seizure is associated with staring episodes. Which one do we talk about when it looks like the patient's just staring? What is it?
Petite mal.
Very good. So nowadays we call them absent seizures. The old term you used to hear is grand mal and petit mal. You'll still hear those terms sometimes used, but they're not, when you're looking at like NCLEX and stuff like that, they call them tonic-clonic is your grand mal seizure, which is what most people, that rhythmic back and forth tightening and relaxing of the muscles. And the petit mal is your absent seizures, which is the staring type episodes. These can be difficult to diagnose because it's not always apparent that it's a seizure. Oftentimes teachers or whatnot will complain they're not paying attention, they're not listening to me, they're just daydreaming, and then come to find out they're having seizures. And they're not purposely daydreaming. So they can be at first difficult to diagnose. Awesome. Primary nursing concern in a patient having a seizure. I know y'all know this one. It is safety. Safety is your primary concern. You want to make sure the patient is on their side, nothing's near them, their head's protected. You don't restrain them or put anything in their mouth. You want to keep them from harming themselves as best as you can. The appropriate pinna placement, oh Lord, say that 5 times fast, of a patient over the age of 3 years. Over 3, we're going to do what? Pull which way?
Backing up. Backing down, little babies.
Down and back, isn't it?
Yeah, well, up and back. Remember, if they're over 3, they're a bigger person, so we're going to go up. If they're under 3, they're a little person, so we're going to go down. They're both back, so it used to be out and back and all this stuff. Now it's just back for both of them. So up and back is for your big kids, down and back for your little kids, and the cutoff is 3. And then I already answered that part. All right. Make sure. Yep. There you go. Let's see if you remember how to do this. Your patient weighs 22 pounds or 50 centimeters tall. Patient is ordered to receive 40 milligrams per milliliter squared of a medication. What is their dose in milligrams? Let's see. Oops. I didn't mean to do that. But there's the first part. It's a nice round even 10 kilos. So first we got to figure out what our weight is in kilos. Hopefully y'all are at least know that part by now. I'm really concerned if you don't know the conversion for weight. So then after we figure out our weight, we take our weight multiplied by our height, divided by 3,600. We take the square root of what that is. So our meter squared for this patient, the body surface area of this patient is 0.3726 blah, 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 meter squared. That's our body surface area, but we still need to figure out what the dose is based on that body surface area. So when we take that body surface area, multiply by 40 milligrams per meter squared. If we round to the whole number in this case, it didn't tell you in the question, but if we rounded to the whole number, we would give 15 milligrams. If you've forgotten those, go back and review. There it goes. Any questions on any of those? Y'all know what you're doing. Whoa, was that thunder? Alrighty, let's see how you do on the second round. Let's see. Share. Ah, whoopsie. I don't know what happened. I must have hit something. Alright. Let's start with growth and development and see where y'all are at. Providing a limited number of choices promotes this developmental stage in the toddler child, and really it helps with toddlers, preschoolers, even school-age children. What is their developmental tasks? And providing them choices that can help with. Yes, very good. Independence, autonomy. So in toddler, we start with autonomy versus shame and doubt, right? And then it goes on up to your preschool and your school age also are based on developing some level of independence. So all these stages really, for allowing them to be part of the solution helps. Now, when we're talking about toddlers, you can't give them a bunch of choices. You can't give them 10 or 15 different choices of what to eat for lunch, because then they're just going to be overwhelmed and it's going to end up in tears and a breakdown. If you give them like 2 or 3 choices, then it helps them narrow it down and make them feel like they're part of the solution. Yeah, exactly. Yeah, bigger battles. I know that's right. The standard pattern of tooth eruption in an infant, what age does the first tooth typically appear textbook-wise?
6 months.
Yep, 6 months is usually when you see that first tooth. And textbook-wise, how many, well, shoot, I thought I had that as a second question. Never mind. It begins at 6 months, and typically textbook-wise, they get 1 tooth for each month after 6 months. So if you're talking about, say, a 13-month-old, you would expect them to have around 7 teeth. Now, I know in real life, children don't just pop 1 tooth at a month like clockwork. A lot of times it's like a couple at a time, and they don't have any for a couple months. So, but that's the average where you can count their teeth and see if they're on track. Developing intimacy and identity, as well as adjusting to rapid body changes, are all associated with which developmental group?
Adolescence?
You are right, adolescent. So probably the rapid body changes stemmed you off anyway, even if you didn't know the rest. But they are going through so much. Not only are they going through puberty or just after puberty, but, you know, intimacy, identity versus role confusion. That's their big developmental stage. And it's not just identity for knowing who they are, but there's so many aspects to that identity, whether it be identifying, what college they want to go to, what they want to do with their life, the types of friends they want, their sexual identity. Trying to think of some other things. There's so many details that encompass identity, so it can be a very challenging time for a child. The expected growth in weight of an infant during the first year. What does their weight do? Where are they at 6 months versus a year?
Triple.
Yep, double at 6 months and then triple at a year. Very good. I think y'all know that. Usually they gain after the infancy period. They typically gain about 10 pounds a year. A down and dirty way to kind of remember weight. Like usually a 3-year-old is around 30 pounds, a 4-year-old is around 40 pounds, etc., up until you get to 100 pounds at 10. Typically your school-age children grow 2 inches a year in height. I'm trying to think if there's any other, like, calculation type. Not calculations, but I think that's about it. Those are the big ones. Improve separation, communication skills, and control of body functions are all goals at the end of what developmental level? When they finish what developmental level should they be able to control their body functions, have better communication skills, improve separation? Think about what happens at the end of a stage. Not at the end of school age. It actually happens at the beginning of school age. Because right before school age, we have our preschooler. So at the end of preschool stage, improve separation. Thinking about it. Think about these patients. These kids are starting to go to school. They're going to be away from their parents more often. They're better learning how to use full sentences, how to write. They're also, by this point, typically they should have learned how to control body functions like bowel and bladder. So by the end of preschool, you would expect these milestones to be developed. Yeah, isn't that the truth? The best way to prevent osteomyelitis is to do what with wounds? Clean them. And of course, hand hygiene is always the answer to everything. Hand hygiene, I mean, what's the point in washing a wound if your hands are dirty? And then good wound care. This will help prevent bacteria from getting into the wound that can then get in further and infect that bone underneath. We don't want that happening. Osteomyelitis is a beast to treat. Long-term growth problems are a primary concern with this location of fracture if it occurs on a what?
Epithelial plate.
You got it. So growth plate or epiphyseal plate is the fractures we are most concerned with pediatric patients because the scar tissue that can form there does not grow the same way that regular cartilaginous growth plate tissue grows. So it will, that they might have one extremity that's shorter than the other or things like that. It sure does, doesn't it, Ashley? These are some primary concerns in a patient in traction. So I'm not talking about a specific type of traction. Just to take a trip back to med-surg, what are we going to be looking at with traction?
Skin integrity.
Skin integrity.
Never moving.
Huge. Never. Yes. Oh my gosh, y'all are awesome. So skin assessment, skin integrity. You know, these patients, we can't really turn on their side like we want to. A lot of times all we can do is kind of shift their hip a little bit or whatnot. So monitoring their skin integrity and also doing as much as we can to maintain that skin integrity. Checking those neurovascular assessments, those 5 Ps, making sure they got good perfusion. Checking for infection. When they have skeletal traction. They've got the pins embedded in their bone that are holding it together and then applied to the pulley system. So those pins, because they are an external device, create a avenue for infection right in the bone. We also want to make sure we're doing pin care as part of that. And then those weights, we don't want to disrupt those weights. We don't want to take them off. We don't want to put a pillow under them. We don't want to do anything that's going to change that weight, because then you're changing that prescription and it can cause disruptions in the healing of that bone. Y'all got this. All right. Having the child bend forward at the waist with their hands together hanging down. What are we assessing for?
Scoliosis.
Scoliosis. Very good. So we're looking at when we have them bend, before we even have them bend over, we're looking at shoulder height, make sure it's symmetrical. We're looking at hip, make sure it's symmetrical. We're also, when we have them bend over, we're looking to see if there's a lateral curvature. 5 P's. What are the 5 P's? I'm going to tell Ms. Dietrich if you don't know the 5 P's.
Pain, paraparesthesia, pain, paraparesthesia,
Paralysis.
Yep. Oh, where'd my cursor disappeared? There it goes. Pain, pulse, power. Yep, y'all got it. And then poikilothermia. I had to look it up. There's this P word, and I can never remember the P word, for decreased temperature, where the site feels cool to touch. And I can never remember it. I had to look it up during the day class. So, poikilothermia. Not that you're probably going to see that word again, but just basically looking for decreased temperature where it feels cool to touch. We always focus on the 5 P's, though. All right, the best routine palpable pulse site for a child over the age of 2 is what? Where are you going to?
Radial.
Yes, radial. How about under the age of 2? Where are we going to feel for it? Think back to CPR. Where do you check a pulse in an infant?
Brachial.
Yes, brachial. So in between that mid-humeral shaft, basically, we're checking for a pulse. The best overall site under the age of 5, though, is going to be apical, listening for a full minute. Because remember, young children can have irregular heart rates, which is normal for them, but we wouldn't want to have an erroneous number because we didn't listen long enough. The method for determining an infant's adjusted developmental age for infants who were born preterm. So if they're preterm, I don't know if you remember back, we talked about this when we did newborns, is you want to adjust their age based on what they would be if they were full term. So if you have a 1-month-old, or I'm sorry, a 2-month-old, but they were born a month early, you're going to evaluate them as a 1-month-old because they're not going to be at the same developmental level as a 2-month-old, even if that's their chronological age. They're going to be based on where they would be if they were full term. All right. So this answer is going to be a lot easier than you think it is. Don't overthink. This can provide assessment information of the child's relationships. It can provide a means of expression. It can provide a sense of accomplishment, distraction. It can help establish a good rapport. And it can be done through many methods, including art and video games. What's a general term? Keeps popping up with these white boxes instead of showing me what y'all are actually.
Therapy.
What kind of therapy?
Art.
Not just, it includes art.
Expressive.
Play. Super simple. I knew you'd be like, wait a minute. Play. So just play therapy in general provides you with all of these means. We use play. If you like to play, Peds is for you. And it's not that we're slackers and we're not taking care of our patients. It's that actually needs to be a part of our nursing care. All right, this is common in younger children and describes the need for routine. Same object, same circumstances. They want to wear the same princess dress every day, or they want the same blue plate. You'll see this with patients with autism, but you also see it as a normal occurrence at younger ages. What is it called?
Repetition?
It is something with, that's not the name of it, but it does have to, they need repetition.
Ritualistic?
Yes, ritualism. Very good. So this is a description called ritualism, where they need the same thing over and over and over again. And in younger children, this is normal. You will see this in patients with autism, though, where it continues, where they need to have very routine, specific things that occur, or can really disrupt their day. Yeah, it has some of those kind of similar characteristics like OCD. A good way to improve compliance in a child. So one way we can improve compliance is giving them choices. I mentioned this with toddlers, preschoolers.
Choices.
Yep, exactly. Letting them be part of the solution, not just dictating to them what to do. So letting them make choices, letting them make suggestions. Obviously, from a 3-year-old or a 4-year-old, their suggestions may not be legitimate, but they might be. So letting them be a part of the process. All right, the most important factor when determining toys and play activities for a child is what?
Safety.
Safety, number one factor when we're looking at play methods for children is it safe? Will they choke on it? Does it have pieces that will break off? Not only for choking, but if pieces break off, especially you see with plastic toys, that edge can be sharp and they can cut themselves with it. Not to mention, can it be cleaned? Can it be sanitized so it's safe for them as well? The second most important factor is you want to make sure it is appropriate for them based on their developmental age, not their chronological age. It doesn't matter if they're 10 years old. If they have the mind of a 5-year-old, then that toy based for a 10-year-old, they're not going to enjoy it and it's going to be way over their head. So the second is making sure it's appropriate for their developmental age. These would include appropriate safety teaching parameters for infants and toddlers. What are some things we can teach parents to keep our infants and toddlers safe? Yes, car seats. So at least for 2 years, they should be rear facing.
Lock meds and cleaners up.
Yes, absolutely. Anything that could be poisonous or toxic, we want them up high and locked away.
SIDS, like suffocation?
Absolutely. SIDS is super important as well, making sure they lay flat on their back when they go to bed so that they don't risk suffocation. Using rails, yes, using side rails or anything that's necessary to keep them from falling. Water temperature, yes, water heaters should be 120 degrees or less. Never leave them alone. Never leave them in areas where they could fall. Also, removing anything that could be slippery, like scatter rugs. I know y'all talk about this with like older adults, but it applies to younger children as well. Infant gate should be at the top and the bottom of the stairs, because if you've just got it at the top, well, they've already gone to the top before they end up falling down, and vice versa. Covering electrical outlets, making sure that things like toilets have locks on them, refrigerators, appliances that they could get stuck in and may not be able to get back out of. I think y'all pretty much know those. Y'all are good about those. All right, the most common cause of death in the adolescent population is what?
Car accidents.
Very good. Automobile or car accidents, motor vehicle accidents. The most common cause of death in all of peds is accidents, but it does change with the population. When we're talking about adolescents, motor vehicle accidents. Important parameters for infant nutrition. What do we never give them the first 6 months of life?
Cow's milk. Cow's milk.
Well, that's for a year.
Water.
Water. Very good. So I'm glad you brought that up. So no water for 6 months. We shouldn't give them anything but breast milk or formula for the first 12 months. So not until they're 12 months should they have anything besides breast milk or formula as the main source of nutrition. Honey, we should not give them as well, but that's not because they can't digest it. That's because they can get botulism from it. We want to make sure that they are diluting formula appropriately if they're using formula. What age do we start solid foods?
When they show readiness cues.
Yes. Around what month is that?
6.
6 months.
Very good. So about 6 months is when it is recommended to start them on solid foods. And not that you need to know this. They do recommend you start with grains because it's the easiest on the stomach, like your rice cereal, stuff like that. Then you go to vegetables before fruits. And the reason they say vegetables first is because vegetables aren't as sweet. So if you start fruits out first, they're less likely to take the vegetables. So vegetables, then fruits, then meats. What's another one? I think there was something else. This will probably tell me. Oh, that's what it was. That's what I was thinking. And we also want to teach parents not to add cereal to formula, except for in very specific circumstances. Like when we get to GI, we'll talk about with reflux disease, sometimes with severe reflux, under doctor's care, the doctor will instruct the patients to add rice cereal to formula to thicken it up so it's a little bit heavier so it doesn't reflux as bad. But under normal situations, we shouldn't be adding rice cereal to formula for a couple reasons. One, it can be a choking hazard. For two, it can make them gain excessive amounts of weight. So no cereal added to formula except if it's under a doctor's care. Yeah, you're not supposed to do that though. Ooh, 2 months. That's so early. But yeah, I have seen babies get it at 2 months just for GERD. It's so early. And they seem to do okay once they get used to it. Yeah, and that's usually what they'll prescribe it for. Or not prescribe it, like you got to get a prescription for, but assign it to be given is for reflux. Which immunizations do we not give prior to 12 months of age? Early childhood immunizations.
Hey, varicella and rubella.
You got it. So varicella, Hep A, MMR. All of these start at 12 months of age, and it's not because they're harmful if you get them before 12 months. It's that the body's immune system is not going to respond to them earlier than that like it needs to, so they have to get redosed. So under 1 year of age, there's tons they get, and they get multiple doses. They get DTaP, Hep B, Rota, Hib, PCV, which is your polio, influenza, starting at 6 months. So they get most of their vaccines, or a large portion of them, within that first year. Lots of immunizations. The priority intervention in a patient who has an unexpected outcome, if y'all don't know this by now, like if they have a med reaction, what's the first thing we're going to do?
Stop med.
Remove the cause. Stop it. Very good. We need to get rid of whatever is causing it. Like if it's a med, for example, stop the IV infusion. All right, concrete and logical thinking, including cause and effect, as it's supposed to say, as well as increased socialization and participation in group activities, is related to what developmental stage? If you don't know what concrete thinking is and what stage it is, you got some review. What stage uses concrete thinking? It keeps showing up blank. Not adolescence.
School age.
School age, very good. Oh, dang it. So school age children are those that use concrete thinking. By the time you get to adolescent, that's when they start looking at that abstract type of thinking. All right. The moral development of this stage is based on wanting to please others. Praise and criticism are important at this time. I'm going to give you the answer because it's the same one as the last one. So in the school age child, when they're talking about how they gauge their behavior, their moral development, they're really focused on wanting to please others, wanting to please their parents. They really want to get that A report card put on the refrigerator, for example, versus toddlers and preschoolers, they're more focused on punishment, so that's why things like spankings work well or work better in those younger groups. It's a lot of lifespan, so a lot of this is review. So by the time they get to school age, they're really focused on, I want you to think highly of me for what I do. All right, this describes the disorder in which there is an alteration in the production or absorption of cerebrospinal fluid. What is it?
ICP.
What's the disorder that can cause them to have too much fluid, which could then thus increase their intracranial pressure?
Hydrocephalus.
Hydrocephalus, there you go. So hydrocephalus, which literally translates to waterhead, it causes, they have an overproduction, but more than likely it's where it's not draining appropriately, and they have this buildup of fluid in their head. Now, if it's not addressed, it will cause increased intracranial pressure. A common concern of adolescent patients that is not seen in other developmental groups, especially hospitalized patients, what are they worried about when they get sick or hurt or things like that?
Body image.
Body image.
Yes, they are very concerned about things like scarring, alterations in their body image, how they're going to look, and they're a lot of times more concerned with that than just how sick they are. When you're talking about all populations, adolescents as well as school age, toddler, preschool, they are also going to be worried about pain. Everybody worries about pain. Nobody wants to be in pain. Body intrusion, what they're going to be doing to their body, and then separation anxiety. That crosses all developmental groups. So let's see if you know this math, because y'all struggle with these. Patient is ordered to receive 1,000 milligrams of a medication. This medication is diluted in 500 milliliters, and it is to be given over 90 minutes. What is going to be your rate of infusion in milliliters per hour? There's only two numbers you really need in this equation. And I'll give y'all a minute to think about it. Yep, I sure can, Nayaretta. I'll go back to it right after we do this one. Whoop. Darn it. There we go. All right. So we're giving a medication that's 1,000 milligrams. It's diluted in 500 milliliters, and it's given over 90 minutes. What are we looking for mils per hour? What y'all think? Is Judy correct? 333? I'd say, yes, she is correct. Very good. So in this case, now, if it had given us a concentration, like let's say it said we're giving 1,000 milliliters and the medication is diluted 500 milligrams per 2 mLs, then we would have to figure out how many mLs that patient is getting based on their dose. However, in this case, it tells us how many milliliters they're getting. We don't need to figure that out. It's just a constant. And then it tells us how long to give it over. So we need volume and we need time. The volume is given to us. We don't have to figure the volume out. So we do 500 over either 1.5 hours, if that's how you like to do it, because 1.5 hours is the same as 90 minutes. Or if you like to look at your conversions, you can also do 500 milliliters over the 90 minutes, leave it how it is, but then multiply by 60 minutes per hour to convert that. Y'all so smart. All right, let me go back to the last one. Hold on, I gotta go home first. There we go. All right, so when we're talking about common concerns of adolescent patients, they are worried about how they look, body image disturbance, things like that. When we're talking about all of them, including adolescents, but also school age, toddler, preschooler, they're all worried about pain, body intrusion, and separation anxiety as well. Is that the one you were talking about, Nayaretta, when you said the last one? Okay, perfect. Yay! Close that. All right. Are there any questions I can answer? Clarifications? Confusions?
Yes. So with the meningitis, you said the difference between the symptoms of meningitis and increased intracranial pressure is that fever.
Correct, because meningitis causes increased intracranial pressure because of the inflammation going on with the meninges. So those symptoms that you're seeing are not the meningitis, it's that increased pressure in the head causing those symptoms. So you'll see it with meningitis as well. Does that make sense? Okay, perfect. And then one thing you do see with meningitis, you're not going to see with increased intracranial pressure that's specific to meningitis, is that nuchal rigidity, where they have that stiffness in their neck. In fact, if you try and force the flexion of their neck, it will actually cause that right leg to lift up by itself. The Brzezinski reflex. Coming back to med-surg a little bit. And you thought you were done with med-surg. Never. What's this flashing? Oh. All right, what can I answer for you? Anything.
So I do have something. So are titrations not going to be on this exam? Will they be on the next exam?
Maybe.
Or the final exam?
Yeah, that's more, we focus on that for maternity, like with labor and delivery, Pitocin and stuff like that. So I wouldn't worry about that.
Okay.
When you're doing titrations, remember, don't let it be overwhelming. Think about, and a big reason I like to cover titrations right now is because guess what's going to be on your dosage calc in Med-Surg 2? Critical care titration. So don't forget about it. For titrations, is that what you mean, Jeanette? All right, so let's say you have a patient, their dose is 0.1 to 1 milligram per kilogram per minute of med. And I'm typing it in the chat so you can see what I'm saying too. So let's say you have and it's titrated to effect. We're not going to talk about, usually it'll tell you in the order, like titrated to a MAP of 60 or whatever it is that you're relating that to. So let's say you have an order dose of 0.1 to 1 milligram per kilogram of medication. Patient weight is, we'll just convert it, 25 kilograms. The concentration is, let's say 400 milligrams per, not 400 milligrams per, well, let's round it out, 500 milligrams per 100 mLs. What is the rate in mLs per hour if the max dose is given? Let's say that. All right, give me a second to figure this out because I just kind of made it up. All right, so let me know when y'all get it and we'll talk about it. Not 5, and I have a feeling I know what y'all left out. Look at the order dose. Is it milligrams per hour? Natalie and Judy got it. So that's exactly what y'all have, and that's what most people forget about because you're so used to looking at per hour. Oftentimes your titration doses are in per minute doses, but you're looking for per hour milliliters. So make sure you don't forget to multiply by 60. So if you got 5, that's what you left out. So for example, in this case, we are giving 1 milligram, if we're giving the max dose, 1 milligram times 25 kilograms give us 25 milligrams. But then because that's 25 milligrams per minute, we need to know, because we're looking for milliliters per hour, we need to take that 25 milligrams per minute, multiply by 60 minutes per hour, because we want to know how many hours it's going to take. And that's going to give us 1,500 milligrams per hour that this patient is getting. It's just a time conversion, that's all. You're going 60 minutes to an hour. It is one conversion. It's a very basic conversion. And that's it. Once you recognize that it says per minute, and get used to looking at titrations as per minute, because most of your titration medications, your dose is ordered per minute, but you as the nurse are programming on the pump how many milliliters per hour. So when you figure that out, that they're getting 25 milligrams per minute, 60 minutes per hour, they end up with 1,500 milligrams per hour, and then y'all know the rest. 15 milligrams divided by 500 milliliters times, and 500 milligrams, per 100 milliliters. And that gives you 300 milliliters per hour. Does that make sense? Don't forget, that is the one step people usually leave out. They do everything else, and they forget to convert the minutes to the hours. Because like you said, Essence, you're so used to everything being in hours. I promise you, if you just break down titrations, don't look at the whole problem. Break it down step by step, because titrations, there is nothing in there you have not already used. It's just putting multiple steps together. That's all it is. And if you break it down instead of looking at the whole thing at one time, it will make more sense. Absolutely. I'm glad you asked me. So there is under the math folder in your introductory docs, there is a PowerPoint in there. There's some practice questions. Your clinical calculations books have a few. I know under the maternity one, it actually has a Pitocin question in there. Did I put something else? I'm trying to think if I put something else in that folder. Intro math. Oh yeah, there's a couple of videos in there as well. Now one is about dopamine, one's about heparin, but they kind of walk you through the steps as well, showing you a different type of procedure. I'm glad that helped, because I want y'all over break to be practicing those, because they will be on your dosage calc. They're not going away. Remember, there is nothing in those problems you have not used before. Just keep that in mind. It's nothing new. It's just putting it together. Yeah, all classes that have dosage calculation tests, it's always 20 questions, 90%. That's across the board our policy. That doesn't change from class to class. Reconstitution. We've been doing reconstitution. That's in a lot of classes. You started that back in mid-surge.
So I have a quick question, Ms. Martinez. You know how every semester is different math? So is MedSearch 2 more different formulas, or is it just everything we've learned together? Or do you not know?
Not answer that. I mean, a lot of it is going to be stuff you know, but at a more critical level.
Oh, okay. Thanks.
Mm-hmm. Any questions?
Thank you so much, Ms. Martinez. You have been amazing. Thank you.
Thank you. You know, like I said in the A class, I've already written the test. No need to suck up now. You are welcome. Anytime. I know. I'm just playing.
Okay, so for this homework, this pediatric care homework that I got the number for the ATI, I haven't looked at it yet. How many questions roughly is it so I know how long I got to sit here?
Oh, gosh. It was either 40 or 50 questions. I want to say it was 40, but it might be 50.
Okay.
It's been over a week since I looked at it now. I think it was 40, but it might be 50. Okay, so yeah, it is 40.
Thanks, Jen.
So spend a long, long time. And review the rationales, too. Don't forget to review the rationales. They can greatly help you. Homework assignments should not just be BS waste of time. They can help you if you really use them. If you just go through and answer questions and move on, they're not going to be as helpful, but...
So still above 80% and then send you the thing, right?
That's correct. You'll upload it just like you normally do. And then I'll be reviewing your projects over the next week and grading those. Yay! I hope y'all enjoyed it, doing them at least a little bit. I think they can be very helpful. Good. I'm glad. There really is. And a lot of times, even as nurses, we don't even know what resources are out there. Think of how much our patients are missing out just because we don't know what to refer them to. Or we don't even know that we can refer them to a social worker, and they may know research, even in-house social workers in the hospital. Exactly. If you're that in between, if you're below poverty level, there's a lot of things that you qualify for, but there are so many people that are just above that poverty level that have such a low income that they're struggling, but just enough that they can't get any help. And it's really disheartening how so many people fall right in that middle of that category. Yeah, exactly. It's really disheartening. And I don't have an answer. I don't have an answer for it, and that's where a lot of volunteer services come in. So instead of like governmental services where you have to meet a poverty line, that's where a lot of those volunteer services come in, and those other organizations. I don't know if y'all saw, speaking of, I am so excited about this, that Chesterfield's doing this. I just saw an article today for those of you that live in Chesterfield County. Their plan is to go all virtual. Yeah, I'm excited too. It's okay. I roll on cue. No, I do believe homebound is better for safety wise, but one thing they're doing is they're not going to furlough people like bus drivers and cafeteria workers and things like that. They are still going to prepare meals and have bus drivers deliver them to the neighborhood so that these children can eat, even though they're not in the buildings in school. I am so excited about that they're looking out for that. And that way people don't have to be laid off as well. So it's a win-win-win for everybody. Yeah, exactly. And they were talking about like administration and stuff like that. They'll be helping out with cleaning and sanitation. Some of the cafeteria workers will do that as well. So instead of laying off people, they're finding a way to differently utilize them, which is awesome. If we can be creative instead of not using our resources that we have. It's so much better for everybody. We need to form like a Bryant and Stratton nursing program homeschool co-op. For us and y'all. Like, all of us could get together and form one big co-op, teach each other's kids. Wouldn't that be nice? I know. I don't know how yeah. Exactly, Asa. Take turns. Although, Thursdays would be a struggle because almost all of us as instructors have a class on Thursday. All of y'all. That's right, Jeanette, you did. So I hear that you're volunteering to be the homeroom teacher and head everything. Hey, I taught once in my life too. Just kidding. I've had that conversation though with my husband though that, when the kids, even in kindergarten, some of the stuff they would come home with, just the way they wanted things done. I'm like, I have a master's in education and I can't figure out how to teach my own kids that are in elementary school. It's just a different thought process. Yeah, parents are the worst, Jeanette. I can only imagine what those teachers go through having to deal with what some of the parents put them through. Yeah, I know. Your own kids are always the worst. That's it. Yeah, my kid didn't do any of his work all year, but you're going to pass him, right? I don't understand it. I actually had to ask my daughter's 5th grade teacher last year. She started out the year not wanting to do her homework. She's never been that way. I don't know why. I had to actually ask the teacher, no, I don't want a 50. I want a 0 if she doesn't do her work. And it only took a couple zeros for her to get her head out of her butt and start doing her work. And they don't do it. They don't get a 50. But that's the policy at most schools now, that if they don't do it, they get a 50. And that's crazy to me. Exactly. We've really gotten off track. I'm so sorry, y'all. Is there anybody that has legitimate questions, or am I just holding y'all up? Those of you in my clinical, I tend to get sidetracked sometimes when we get into conversations. Okay, perfect. Absolutely, anytime. Any questions, thoughts, impressions? Nothing. All right, guys, if y'all are good and you don't have any questions for me, I'm going to let you go so you can take a break. I know, right, Jeanette? Give your kids an extra hug. You never know. And I will let you go so y'all can get some dinner, or those of you in the day class can move on and get something else done. You're welcome. I will see some of you this weekend, some of you Monday, some of you on Thursday. Enjoy your week. Study hard. Think of me all week. I'm sure you will. Bye.